My name is Mary Jo Murphy, and this is the 6th patient seminar for the International Anal Neoplasia Society. This is a big month for anal cancer awareness, so we're very excited to be doing this. This seminar called the Anchor Study, What Does It Mean to Me? Where the seminars come out of questions that we get from patients. So this was one that was a popular topic.
And welcome everyone. We're so glad that you could join us for this session. My name is Dr. Linda Hips. I'm an OBGYN in Allentown, Pennsylvania. I would like to have Emily introduce our speakers, and we're very lucky to have them presenting today.
Maybe before we start, though, we could do our
memory.
Yeah.
Yes, one moment.
Okay. And this session is in memory of Paulette Crowther. She was diagnosed with stage 4 anal cancer, and even though she was up to date on all her recommended cancer screenings, after her passing, her 3 children started the Anal Cancer Foundation to eradicate anal cancer. One of its first initiatives was creating and leading the advocacy coalition that pushed for Anchor. So this is Justine Almada's mother, and we are honored to remember her.
My name's Emily. I'm a nurse practitioner in Chicago. I also am a sub-investigator with the Anchor study out there. And I'm so happy we have 2 amazing presenters today. We have Dr. Hilary Dunlevy, an assistant professor in the Division of Infectious Disease, who has an interest in caring for infections, people living with HIV, and caring for people with anal dysplasia. She moved to Colorado for her fellowship in infectious disease and is currently faculty at the University of Colorado. And then we have Julia, who has a master's in public health. She is out of the University of California in San Francisco. She has supported the Anchor study from the initial planning and is proud to continue managing the trial with research team through the completion. She has served as various roles in clinical research management in oncology for over 17 years, including writing clinical protocols, managing research data, and ensuring regulatory compliance with the AIDS Malignancy Consortium operations and Data Management Center. And she was previously project director at the Anchor Data Management Center. We're very lucky and very excited for this presentation. So thank you guys for joining us today.
Awesome. All right, I'm Hilary. I'm going to go ahead and start. Thanks everybody for joining. So we're going to talk today about the Anchor study, and thank you so much for the introduction, Emily, and we're excited to be here. Go ahead, Julia. And so we wanted to let you know we don't have any disclosures related to this presentation, and then also that we're really grateful to the Patient Outreach Committee for inviting us to speak today. The patients, their experience, and their overall health and general well-being, that's near and dear to both Julia and myself. So thank you. Next. So we'll talk for about 25 minutes, just kind of filling in some background information and letting you know what we found in the Anchor study. And then we'll take some time for some questions and answers. We may not be able to answer all of your questions, but we'll give it our best go. Next. And I'll talk a little bit about the background to start. Next. first of all, many people, and you're probably all familiar with this, many people don't totally know where exactly the anus is. It's a word that we don't say that much in our day-to-day, but the anal canal is just the last 2 inches of the GI tract. It's covered by squamous cells, which are the same type of cells that cover our skin. And then it also covers the area around the outside of the anal opening. So on the inside, it's a couple inches in, or about 5 centimeters. And on the outside, the anus is considered to be about 5 centimeters around the outside of the anal opening as well. So you can see this is a slice through somebody's colon, and then at the very end, that sort of lighter part is the skin. And then the sphincter is right there, and that's the external sphincter that we control when we have bowel movements. So anal cancer is cancer in any part of the anal canal or the perianal area, which is the area around the outside of that anal opening. Next slide, please. So human papillomavirus is the virus that we talk about as being related to about 91% of anal cancer. And so there are many different types of HPV or human papillomavirus. Over 200 are found. Some of them cause warts on the skin, others cause genital warts and anal warts. And those are specifically types 6 and 11, which many of you are familiar with. And then there's other types of HPV that can cause precancerous and cancerous lesions. So HPV 16 and 18 are the most common types that cause those precancerous lesions. And so HPV is super common. And so that's why, we feel like we need to be able to talk about it openly. People talk about it like a sexually transmitted infection, which it is, but it's something that should be spoken about regularly with patients, helping people to understand that, 80% of us are going to get this at some point in time. And all of our bodies react to it differently. In some cases, it can stay in the body for long periods of time and cause changes to the cells and lead to cancer over time. And in other situations, the body helps to kind of clear away the HPV, that viral infection, and prevent it from causing abnormal changes to the cells. Next slide. So this is a graphic just to show you what high-grade squamous intraepithelial lesions are. So squamous cells are skin cells. So they're the cells of the anus and around the anus. And so those are the cells that are infected with HPV. And HSIL, or high-grade changes, that is a precancer. It's not actually cancer. And so it can come away, it can go away, it can come back again. The virus may stay in the body, and the changes to the cells can kind of get better and worse. So it's something that has to be followed over time. It can also be removed with some treatments, which I'll talk about later. And then it's not dangerous. It can't spread to other parts of the body unless it becomes cancer. And so what we focused on in the ANCHOR study, which you'll hear about, are these HSIL lesions, the lesions that can turn into cancer over time. Next slide, please. So you can see here that the graphic on the right shows that cancer invades below the bottom of the cell. So HPV infects the cell, and it can kind of stay in that bottom layer of cells. And over time, it causes changes to the cells inside the tissue. And so those circular cells show a really big nucleus, or a really big center part of the cell. And that is a sign that these cells have become abnormal. And when these cells are so abnormal, they can invade into the tissue. That's when they go from high-grade changes to cancer. And so cancer, unlike HSIL, cannot go away on its own, and it's not usually treated in a simple way. It usually has to be treated with chemotherapy and radiation. if it spreads to other parts of the body over time, it can be fatal. If it's caught early, it can often be treated, but we'll talk more about that. Next slide. So in folks with HIV, and in the anchor study was in individuals living with HIV, over their lifetime, if they have high-grade dysplasia or high-grade squamous intraepithelial lesions, they can go on to develop cancer 10% of the time over their lifetime. And so that's a pretty high rate of developing cancer over a lifetime. We know that we're focusing on individuals living with HIV, but we know that in the general population, the number of people in the general population with anal cancer is much higher numbers in folks not living with HIV. And so we recognize that our study is in a smaller group, a smaller number of people living with HIV who are at risk for anal cancer, but we want to definitely bring up the point that we know that there's a larger group in the world not living with HIV that's at risk for anal cancer. I see there's a question in the chat. Maybe at the end of our talk, then we'll go ahead and do question and answer. Is that okay? Next slide, please. So this shows you that in the US, the rates of cancer are going up over time. So we started in 1975 and go to 2009. Those numbers continue to increase up until 2023, where we are now. And you can see that the number of women getting anal cancer are higher than the number of men. Next slide. And you can see here that almost 10,000 individuals will be diagnosed this year, and 2/3 of those will be women. Worldwide, 50,000 people were diagnosed with anal cancer in 2020. We think that's likely an underestimation, given that in many parts of the world, it's not screened or found in the same way that we might find this here in the United States. Next slide. This is a graphic to show that different groups are at different levels of risk for anal cancer. So on the far left, in the red, you can see that folks living with HIV who are men who have sex with men have the highest rate or the highest risk of anal cancer. So if you are 60 or older living with HIV and are a man that has sex with men, then you have a risk of 108 per 100,000 of having anal cancer. So you can see that the rates are high in other groups as well. In women and men that don't report sex with men, there's still high rates of anal cancer in those groups. And then in women with a history of vulvar cancer or vulvar precancer, there's pretty high rates there as well, close to 50 per 100,000. In the general population, it's 2 per 100,000. So you can see that there's 25 times the rate in women that have a history of vulvar cancer. And then finally, the group I want to highlight here are in people who are immune suppressed. So people with a history of organ transplantation who had their organ transplanted and have been on immune suppressing medication for more than 10 years. Those folks have rates around 50 per 100,000 as well. So really high rates compared to the general population. Next slide, please. Why do we care about preventing anal cancer? Well, we care about preventing all cancer. That's one fact. But early detection of anal cancer, we can prevent it from causing death, but we can't prevent it from causing a lot of the side effects from the treatment. I mentioned that there's chemotherapy and radiation, so there's lots of side effects associated with that, including sexual dysfunction, pelvic pain, and difficulty with regular daily activities of living. in metastatic cancer, when it's already spread to other parts of the body, then people are at risk, at a higher risk for death, in addition to the side effects from the treatment. Next step. So one thing that is helpful for the next generation is getting kids vaccinated. So it's recommended to have kids 9 and up to be vaccinated. And most kids will get it at their 11-year vaccine visit. It's recommended to do HPV vaccination for all kids in the US. It's also recommended to vaccinate adults up to age 26. And then it's now recommended, as of a few years ago, to make sure we vaccinate folks up to age 45. It's not a blanket statement, vaccinate everybody up to age 45, but it's supposed to be about the patient, their provider having a conversation and deciding if someone wants to be vaccinated. As a provider, I'll tell you, I think everyone up to age 45 should be vaccinated. It's most effective, though, in preventing HPV-related cancers if it's given at a younger age. So if we can vaccinate at a young age, we can prevent up to 90% of cancers related to HPV. And that's not just anal cancer that we're talking about today. It's cervical cancer or pharyngeal cancer, vulvar, vaginal, and penile cancer as well. Next slide, please. So great, we have this vaccine. The problem is there's still a high proportion of individuals who have not been vaccinated against HPV. As you can see on the United States map to the left, all the red and dark red states are ones where there's at least 40% of individuals who haven't been vaccinated. And then in addition to that, there's still a lot of parents that have no intention to vaccinate their children for various reasons. And so advocacy will be really important, hoping to get more individuals vaccinated as time goes on. Next slide, please. How do we look for anal HSIL and anal cancer? So the picture on the left shows an anal pap. An anal pap is a blind collection of cells by rubbing a swab on the inside of the anal canal. And those cells are looked at under the microscope to show how if there are any abnormal cells. The graphic to the right shows a digital anal rectal exam where a provider inserts their finger and kind of feels all around the anal canal. They should feel 360 degrees for any lumps, bumps, abnormality. And when they're doing the next step, which is high resolution anoscopy on the next slide, then they're spreading a lidocaine, a numbing kind of cream around the inside. And then they insert the scope for the high resolution anoscopy. They look at the cells, they use vinegar and iodine, and then take a biopsy to cut away a small piece of tissue if they see any area that's abnormal. Next slide. So I wanted to show how this is different from anoscopy. Next. Oops. It disappeared. So the way it's different so anoscopy is when you just look with a clear plastic scope. And then high resolution anoscopy is when you take this microscope that's in the middle and you zoom in and you look at the tissue. You use vinegar and iodine to help highlight the areas of abnormality. And you can look at about 16 to 24 times the magnification of just looking with this clear plastic scope. So the clear plastic scope does not give you nearly as much detail and you're not able to see all of the abnormalities. So next slide. Peggy, it looks like they are recording. I see a recording sign up there. So how is the HRA different from colonoscopy? a lot of patients will come in and they'll tell me, I just had a colonoscopy. I don't think I need to have this exam as well. So the anoscopy just really focuses on that last couple of inches or 5 centimeters of the anal canal, as well as the outside, uses vinegar and iodine, all things that are not done in the colonoscopy. So you can see here, this graphic shows you that the colonoscopy takes a camera that is on the snake-like black thing that goes all the way up and around the large intestine until it meets the small intestine. And it inflates the colon with air so that you can see all the walls of the colon. And this little graphic at the bottom shows you how they loop around the abnormalities and snare or cut them off so that they can be sent to find out if they're abnormal precancerous, but this is precancerous for colon cancer rather than anal cancer. It is sometimes found that on colonoscopy, they can find that last little bit of the canal, they can find abnormalities and biopsy them, and then some people get sent to our clinic for a high resolution anoscopy in that situation. Next slide. So how do we treat it? We can burn off the areas of abnormalities that were found on biopsy, or we can use a laser to remove those areas as well. There's also cream that can be put onto those areas that can help shrink or sometimes remove completely the precancer or H cell. Next slide, please. So now we're moving on to Julia, and she doesn't have to next slide herself. So
thank you, Hillary. Sorry about the minor technical difficulties there.
no problem.
But it's my pleasure to present on a study that I've very much enjoyed working on for the last 10 years. So let's get into the design and the results. So before we talk about what we did in the study, we should talk a little bit about why we needed to do this study in the first place. And one question that was asked, and sometimes still gets asked, is why did we need to do this study in the first place? Cervical cancer and anal cancer are known to be very similar diseases. Both are caused by HPV. In fact, many cases are caused by some of the same types of HPV. Both cancers develop from HSIL. And we know very well from the medical community that treating cervical HSIL is known to prevent cervical cancer. However, this was not learned from a randomized controlled trial, which is now in the modern age our gold standard of evidence that is needed for doctors and regulators to make a decision about guidelines. We learned that cervical HSIL works to prevent cervical cancer from its implementation by doctors throughout the country, and we saw a result in the population with the number of cervical cancer cases decreasing. So HRA got developed much more recently, and there had never been a study done to prove that it works to prevent anal cancer by treating anal HSIL. So this is what we set out to do. And we wanted to do this not only to prove that it works, but also to prove that it's safe and that it's not over-treatment. So what question did this study ask? We wanted to know if treating anal precancer or anal HSIL works to prevent anal cancer. We did this by comparing anal HSIL treatment to close watching or active monitoring. So it really was a strategy study where we compared treating anal HSIL with the treatments that Hillary just described to you, compared to just watching patients very closely in the active monitoring arm. It's also important to note that we only included people living with HIV in this study. And this is because anal cancer occurs most frequently in this group, also as Hillary shared a little bit with some of the statistics. Running this study among people who live with HIV made it possible to make the numbers work, essentially, to run the study in a number of people that we could enroll in a reasonable number of time, and also to focus on a group that is most heavily affected by anal cancer. So to run a study, even in this group, required a very large study. And we opened 25 clinics across the US throughout the study. And this involves substantial support, and we're very appreciative for it, from the National Cancer Institute of the National Institutes of Health. At each of these centers, we certified various clinicians, and everybody who did HRA and treatment on this study had to prove through a certification process that they could perform HRA and treatment to a very high level of quality before they were allowed to open the study. Who was included in this study? Well, to be enrolled, people had to be HIV positive, age 35 or older. They had to have anal HSIL as proven on biopsy and meet a number of other criteria. One of the most important things to us, though, when we were enrolling patients was to make sure that we were inclusive and diverse and represented the population of people that this treatment is intended to help. And thankfully, we were very successful in recruiting a very diverse population to the study. We had over 80% male participants, 80% male, 16% female, and 4% transgender or non-binary or other in terms of gender identity, which showed good representation from those groups. And we also had a broad representation of various races and ethnicities, as those groups are defined on this slide and by the CDC. And these populations were similar in terms of their makeup as to the overall US population of people living with HIV. How many people were included in the study? Well, at the time the study was stopped for success, we had screened over 10,723 people living with HIV age 35 and older. These people had all been invited to a first screening visit at which they were offered HRA as well as anal cytology, the swab evaluation. We found anal HSIL by biopsy in 4,459 of those participants. 6,247 of them were not eligible for various reasons. And we found 17 cancers among those screened for the study. Those individuals were then no longer eligible for the study, and we referred them immediately to appropriate clinical care, which is, in most cases, chemotherapy and radiation. Of the 4,459 participants where we found HSIL, 4,446 were enrolled and randomized. And when we randomized them, we did so to one of two groups. 2,237 were randomized to the treatment arm, and 2,222 were randomized to the monitoring arm by a computer program, just by chance, to one of each. Procedures were fairly similar for each group. The main difference, though, is that in the treatment arm, we treated all HSIL that was observed at the first visit. And in the monitoring arm, at that point, if they were assigned to the monitoring arm, they were sent home until their next visit was required. Patients were then seen every 6 months thereafter. And at each visit, they received the three anal swabs, the first one for a local cytology result, and the other two for research studies. They had a digital anorectal exam with a gloved finger, and then they had high-resolution anoscopy. Biopsies were collected every 6 months or more often if cancer was suspected in the treatment arm. And then in the monitoring arm, we biopsied at least every 12 months, more often if cancer was suspected. And the reason for this is that in the monitoring arm, we wanted to be sure with some of these very small anal HSIL lesions that we didn't biopsy the whole lesion away. We only took enough to make sure cancer had not progressed. If HSIL was found at visits later on in the treatment arm, it was treated, and patients and providers made a decision about which treatment was appropriate. Either one of the ablative methods, where we use heat or light to burn off the lesion, or one of two creams that were applied to reduce the amount of disease. And in some cases, providers use both in a 6-month block. Again, it was a treatment strategy study where they could pick from the treatments offered in the protocol and give what was most appropriate. In terms of study outcomes, people kept coming back for these visits every 6 months, and we are very grateful for those individuals who took part and came back because every visit was really valuable for the amount of follow-up we got to count in this study. We found 9 cancers among participants in the treatment arm and 21 among the monitoring arm. Those patients, again, were immediately referred for appropriate medical care for their cancer. In most cases, again, this was chemotherapy and radiation. In some cases where there were very small early cancers, they may have been offered only surgical treatment with close follow-up. But again, these are for very limited cancers that have been caught extremely early. What did our results show? Well, our statisticians ran the numbers, and again, we saw 9 cancers in the treatment arm and 21 cancers in the monitoring arm. And in this comparison, they not only looked at the number of cancers, but the amount of follow-up we had in each arm over time to say what's different about the rate of cancers in the treatment group versus the monitoring arm. And they found that the rate of progression was 57% lower in the treatment group as compared to the monitoring group. And this result was statistically significant, which means that we have a reasonable level of confidence that this result is correct and wasn't an accident of chance from the group of people that we included in the study. Also, interestingly, we found that the rate of cancers was higher than we expected when we started the study based on prior studies. And this may have been another reason that we found the answer to this study earlier than we expected. So in simple terms, just to make sure everybody walks away with a clear understanding of our main result, we saw a 57% decrease in anal cancer progression in the treatment arm compared to the monitoring arm. And that means that anal HSIL treatment prevents anal cancer more than half of the time and is a successful strategy for preventing anal cancer. One of the secondary questions we asked of this study was, is it safe? And we found largely that study procedures were generally well tolerated. Some of the common side effects of treatment and HRA and biopsy are bleeding and pain that can go away shortly after those procedures. But we found that over thousands of study visits, only 8 participants had serious side effects that had possibly been caused by treatment or monitoring. And by serious, we mean the type of side effect where you need a prescription or you need additional care from a doctor to manage the side effect. 7 of these were in the treatment arm, and 1 of these was in the monitoring arm, and they were the conditions listed here on this slide. So we overall concluded that this approach is generally safe to provide for people who need care for anal HSIL. Next, I'll get into some of the next steps for the study, and then we'll get into some of your questions at the very end. So how did this change the anchor study? Well, as I mentioned, the study stopped early. Large studies like this that are randomized have a group of completely independent experts stop and take a look at the data at certain time points throughout the study to make sure we haven't answered the question early, or it's not going to be impossible for the study to be successful. And they make a recommendation as to whether or not the study should continue. Because there were more cancers than we expected, we got full information on the trial sooner than we expected. The Data and Safety Monitoring Board took a look at the data and recommended that we stop the trial early because it showed we had a successful result. We paused the trial for a brief period after we learned this. We stopped randomizing people to monitoring because we knew it was no longer appropriate given that treatment works. We worked with NCI and all of our sites, modified our research protocol, and we recommend now treatment for everyone and reopen the study to offer treatment to everybody. Participants, however, have a choice. If they prefer to be monitored, they're welcome back. We want to see them, whichever option they choose, but we do recommend anal HSIL treatment if we find it for those people who are continuing in the study. And we are cleared to continue the study until September 30th, 2024, at which point the trial will conclude and our participants will be referred to clinical care outside the study. Beyond the study, some exciting things are taking shape. Various experts and groups are assessing whether anal cancer screening and anal HSIL treatment should become standard medical care. And these are through guidelines that are issued through government bodies and medical organizations such as IANS, who is actively working on their guidelines. And our study leadership has been speaking with the CDC regularly as they are working on their recommendations for screening and treatment in certain groups. And the United States Preventive Services Task Force also recently issued a call for feedback on their initial plan, as they are also going to evaluate the evidence as to whether guidelines should be issued. Once these guidelines are out, we hope and expect that they should influence changes in the kind of care that doctors offer to their participants, offer to their patients, and as well as it may improve insurance coverage for these procedures so that they're more readily available as preventive care. And lastly, groups like IANS is working ardently to ensure that there are plans to scale up availability to perform HRA and treatment. These are challenging procedures for clinicians to perform, and we want to make sure that they can do so with a very high level of quality and that there are enough providers available to care for the people who may be referred for it. What's next for research? So there are a few things that I'm really excited about for Anchor, and we are getting ready to use some of the samples we collected in the study, which was one of our aims throughout the trial. I mentioned that we collected 3 swabs at these visits. We also collected blood, and then we have tissue samples available from the biopsies that were collected during the trial. This is a wealth of information, and we couldn't be more grateful to our participants for providing these samples over time, because they're going to allow us to do some really powerful laboratory studies to help us identify what may be some of the better ways or new targets to screen for anal HSIL or anal cancer, looking at various factors in terms of HPV and also the immune system, and how the body may change over time, particularly in people who are on the monitoring arm, who developed cancer versus those who didn't develop cancer, comparing those samples to see what may be different and what may tell us about which factors over time went a little off and led to cancer developing. So we're aiming to run a number of studies to look for specific biomarkers that will help us predict who's at highest risk for anal cancer. And another thing that we're also really interested in is which cases of anal HSIL will go away on their own. We don't yet know how to predict that, but we hope that through this very large bank of samples, we can run some studies to give us better answers that will then in turn lead to development of better tests to screen and treat people. And while these tests, while these samples are collected from people living with HIV, we hope that these markers and these findings can translate to other groups of people to help us develop the appropriate tests in other populations. Also for next steps and what this means to you, we wanted to touch briefly on, can I stop anal HSIL from becoming cancer, which may be a concern from any participants today who may have anal HSIL or be at higher risk for anal HSIL. We strongly recommend that you continue to get HRA and anal HSIL treatment if you're already in a doctor's follow-up. This is important as lesions can come back over time. We recommend that you continue to care for your own health. One of the best things you can do is to quit smoking if you happen to smoke. And if you have HIV or other conditions that affect the strength of your immune system, please continue your care for that, as that can help your body be as resilient as possible against HPV. And lastly, for all of us, whether or not we're affected by anal HSIL, please encourage those in your lives, your loved ones, if they're eligible for the HPV vaccine, please consider it. Please get it if you can, because it is one of our best resources for preventing HPV and HSIL in the first place. There are a number of ongoing studies as well. Again, we are so grateful to our volunteers who took part in this study, because this finding really opens doors for us to plan new studies on the best ways to screen and treat anal HSIL for anal cancer prevention. And there may be other studies, not just for people living with HIV, but for other groups who are recruiting volunteers, open now or in the future. So talk to your doctor, check clinicaltrials.gov if you're interested, because they may involve other factors such as sample collection, other treatments for anal HSIL. And we hope to see additional studies in the future through the AIDS Malignancy Consortium and other groups, now that we have a way to manage anal HSIL successfully for cancer prevention, should we find it during a study. So in summary, ANCHOR is a historic study. For the first time, we showed that anal HSIL treatment lowers the risk of anal cancer. And we hope that these findings get implemented rapidly for those most at risk for anal cancer to aid in prevention. The results are actively being used to help define new medical care guidelines for anal cancer prevention. So stay tuned as we hope that these will be issued in this year or next. There's still a lot to learn from ANCHOR, and we look forward to sharing more with the community as we learn more from our laboratory studies about which HSIL is more likely to progress and which HSIL may be fine to monitor in different ways. And there's still many questions to ask for other groups. It's important to know that ANCHOR really focused on asking a question about whether or not treatment works, but there's still really important questions to ask about screening. Which is the best way to screen, which groups need to be screened, do different groups need to be screened with different methodologies to identify the people at the highest risk who then need to go on for HRA and anal HSIL treatment should they find it on HRA. I'd like to wrap up the presentation portion of this, again, with deep thanks for our participants who made all of this possible, for the investigators and coordinators at many sites who fought the good fight along with us for many years to make this result possible. Our community advisory board, who was invaluable in helping us address the needs to make this study a success. The AIDS Malignancy Consortium, which is our parent group under which we receive our funding through the NCI. The MS company, who supported us with data management, site monitoring, and many of the trial operations activities. And of course, the NCI's Office for HIV and AIDS Malignancies, who oversees us through the NCI. Here's a list of more resources, and we're happy to share this with you guys if you're interested in learning more. And with that, we will jump into the question and answer portion of this session. And I'll just turn to the Q&A.
So Feline sent in a couple of really good questions already that I can start off with, and then Dr. Hips sent in a question as well. So Feline was asking, if you test negative for HPV after treatment for anal cancer and are not sexually active or totally celibate, can you still get other HPV related cancers? Are there reservoir sites within the body where the virus can hide? So by the way, I saw Terry Dara on the on the call, and Terry, you want to add anything at any point, you just hop right in there. I learned a lot of what I know from her along with others, but so HPV can stay in the cells over time, and some people they can have HPV that is not active and not shedding the virus, so it can't be picked up by those tests that we do for HPV, but the HPV is still there in some cases. And so it's not necessarily a reservoir site, it's the site of infection where it is, and it just stays in the cells. The next part of the question is, what makes the virus activate again? And so the immune system is part of what keeps the virus in check and keeps it from proliferating or multiplying. And so when the virus or when the immune system is compromised in some way, so either through medication that compromises the immune system, like people with autoimmune conditions will often have medication that suppresses the immune system, or like we talked about earlier, organ transplantation, you have to take medication that compromises the immune system. And then folks living with HIV is another example of immune system that may not function as a typical immune system does. So all of those things, as well as age, as we get older, our immune system doesn't function quite as well either. And so all of those things put the virus at risk for multiplying again. And so that can be reactivated. Let's see, the next question. Pauline asked, since most people with anal cancer are women who do not have HIV, at what point do we recommend monitoring for anal cancer? So I think this is, Feline, one of the big questions that we still have, and I don't have the answer to that. I do think we're going to get a lot of information about other risk factors from what we have in the ANCHOR study, recognizing that is, of course, a population living with HIV. But if there are other risk factors that put people at risk, then that'll help us understand for the general population, what are some other risk factors that we should look at more seriously. So there's a question, the first hemorrhoidal symptoms. So I think it's really important, the point you bring up about educating primary care doctors and OB-GYNs about screening for anal cancer. I think the ANCHOR study and the publication of that and the discussion around that will help people, think and talk about it a lot more. As we all know, there is a stigma around anal cancer and talking about anal cancer. And so the more we're able to do it with individuals who are going to be practicing primary care OBGYN, the more we can get them that information, the better screening they'll be able to do. So anybody with those hemorrhoidal symptoms, a lump bump, bleeding, they should have a full exam, including a digital anal rectal exam, and at least an anoscope, if not a high resolution anoscopy. And, they may be able to have anal paps or other screening tools as well. So absolutely increasing education in those general groups. And one of the ways that's being done, the results of the ANCHOR study are being discussed at various scientific meetings just to increase knowledge in the general provider population. And then right now, the president of the ASCCP, which is a cervical cancer screening and gynecology association, that individual, Dr. Lisa Flowers, she's part of the ANCHOR study. And so she is raising awareness within the OBGYN group as well. So I think we all are working to really raise awareness around this. Anything to add?
I think you were very thorough with that one.
That's part of the job description of an infectious disease doctor, being too thorough.
Next one is a question I'm often asked is what percentage of anal paps that are negative or normal could still have HSIL in HIV populations versus non-HIV populations?
Yeah, so I think again, this is information we're going to get specifically about the population living with HIV from the ANCHOR study. So we did, as Julia described, we did anal paps at every 6-month visit, and all of those are correlated with biopsies. There have been studies that have reported very low numbers, very low numbers of correlation of HSIL with anal with abnormal anal paps. And so I think there's still a lot to find out about this. And in a study that was published in AIDS in 2016, it showed really low numbers, like 35% abnormal paps in those with HSIL in folks that are not living with HIV. And so that's still a problem. That's still something we're working to understand. But there are ways to coordinate HPV testing possibly with that. But again, that's information that we're still working towards getting those algorithms together to really identify the most pre-cancer that we can.
Exactly. And that's one of the main things we recognize, that the specificity is quite low. And with the correlative science plans for Anchor, we are hoping to try a number of HPV assays, as well as some additional types of screening tests to see if any of those combinations improve on appropriately finding those people with HSIL, either on their own or in combination with cytology. I don't have the exact numbers, but it's definitely known that that it's not a perfect test, and there is definitely room for improvement in how we screen. And we may need to use different types of tests in different populations, depending on the presence of HPV. HPV is very common in people with HIV. So if all those results come back positive, we may not have the best finding for if it works alone for screening for anal HSIL. Next, we have a question: is the recommendation for HPV vaccine up to age 55, even for people with likely previous HPV infection and or people with HSIL diagnosis?
Yeah, so the HPV recommendation up to age 45 is for anyone who could be at risk for acquiring a new infection of HPV. The vaccine does not treat HPV infection that has already occurred. However, there are 9 different types of HPV that are covered by that HPV vaccine. And so it's likely that most people have not been infected with all types of HPV. And so it could have a protective effect at getting exposed to another type of HPV.
Just as an aside, there was a study giving the vaccine Gardasil 3 doses, a group of patients, women having LEAP procedure, so treating cervical high-grade dysplasia, versus a group that did not have the Gardasil vaccine. And there was a 50% reduction in recurrences with the Gardasil vaccine given post-LEAP in that group. So we were in Rutgers, New Jersey, giving many of the patients the Gardasil vaccine as well, particularly in the population.
I think there's been further study, like maybe that was a retrospective study, and there have been further studies that didn't show the benefit. But I agree that, you know, if there's any possibility that it reduces the risk of recurrence, we need to do it.
Okay.
Next is a question: are we at the stage with anal paps where women's cervical paps were in the 1950s? I would hope we're a little further along at this point, because we definitely know that treating anal HSIL prevents anal cancer, but we are definitely still at a point where there's much to learn about the best way to screen. If that answers the question.
Yeah, well, and one other thing is, when I was looking at that study from 2016 that showed that there was such a poor correlation of the PAPs with the biopsy findings. I think that, the more people practice anal PAPs, the more people are able to get a better sample and are more likely to have a better, more accurate result as well. And so hopefully with more education, the PAPs are going to have better outcomes.
And another question is, can you comment about a question someone said, I only had anal sex a few times. Am I at risk of anal cancer? That's another question that's often asked.
Yeah. And when I do see a lot of women that are not living with HIV that just had an abnormality found incidentally, because we don't have great screening guidelines for women not living with HIV. So one thing, I have some people say, like, I only had anal sex once, or I don't do that, or, things like that. I agree. And one way that we think that HPV may be deposited in and around the anal canal is through wiping after sex. So HPV can be in the fluids, the sexual fluids. And then when women wipe front to back, they could deposit some of the virus in and around the anus. And so, I think that people automatically assume it's from anal sex, and it's not necessarily.
And no, thank you for sharing that.
I'm reminded of Mary Jo's wonderful simile, HPV. It's like glitter. It just gets everywhere.
Like, that's true.
It is. So Terry had a question for you, Dr. Hips. Anal cytology probably has no better sensitivity than cervical PAPs, 50 to 80%. Sensitivity may be better in HIV positive individuals since they often have higher burden of disease.
Yeah, and that actually I attended a grand rounds yesterday. Dr. Cracchiolo in Rutgers, New Jersey, and the population, the HIV population, even without doing PAP tests, more than 50% had high-grade disease. So my concern is I often am pushing to do anal PAP tests, but in the HIV population, potentially we should just be going directly to HRA. Because if we're missing, if the specificity, sensitivity is not good, then are we wrongly thinking that everything's fine when it isn't?
Absolutely.
Yeah, we look forward to publishing more on what we found among the screening population with respect to that relationship.
I think we are all anxiously awaiting that. Thank you.
And then it's
And there was a question, are the proposed guidelines recommending a digital rectal exam for all hemorrhoid patients?
Thanks, Nancy, for putting that in there. So so in order to diagnose the hemorrhoid, you have to either look at it or feel it or both. And so if a provider just tells someone, oh, you have some bleeding from the anus, it's probably, or you have anal bleeding or rectal bleeding, it's probably just from hemorrhoids. That should never be acceptable to any patient because, we don't know what it is unless we look and feel. And so as far as guidelines go, it's not actually written in stone, but that should be a clinical pearl that we all take with us.
We're down to our last minute. And this was incredible. Oh my God. Thank you, Emily, for pulling this all together. And thank you, Linda. Julia and Hillary. Oh my God, this has been amazing. I just want to thank everybody who came to listen to this, and it will be recorded, so you'll get to hear it again to pick up anything you missed. And thank you for attending these seminars. And our next one, it's probably be in the summer sometime. We're going to address male sexuality and the effects of treatment on men. And we also are going to be starting a podcast. I'm not exactly sure when, but keep your ears open for that. We'll be telling you about it. And I want to encourage people to join IANS. We need advocates and patients as well as providers. So thank you everyone for being here, and come back next time.